Hello everyone and welcome to a new video. So continuing our discussion about antibiotics, we already talked about the cell wall inhibitors and the protein synthesis inhibitors. Now we are going to talk about the antibiotics that affect the bacterial DNA, and those are the quinolones. The quinolones arose in the 1960s, and the first agent was the naldixic acid. In the previous video, we talked about the quinolones generations, and in this video, we will talk about the quinolones pharmacology. And in this video, we will talk about the agents, the pharmacokinetics, the mechanism of action, the spectrum, the resistance, the therapeutic uses, and the adverse effects. So let's start. Let's start by talking about the agents of the quinolones. So the agents start with the naldixic acid, as we mentioned before. So naldixic acid, this is the first drug in the quinolones. It worked only on the urinary tract infections. That's because it does not attain significant plasma concentration, so it doesn't attain significant plasma concentration, and it worked only on the gram negatives, so it was the perfect drug to treat urinary tract infections. And other than that, it was useless, and it formed the first generation of the quinolones. After that, the chemists tried to solve the plasma concentration problem, and it was solved by adding a fluorine atom into the structure of the naldixic acid, and we get a drug that's called the norfloxacin, and this drug solved this problem, so it attained a good plasma concentration, but it still have the same problem of the spectrum, which covered only gram negatives, or mostly gram negatives, and it had a half-life, or it attained good plasma concentration with a half-life of 3 hours. Plus the post-antibiotic effect, because those drugs accumulate in the neutrophils, so they have the post-antibiotic effect. So the spectrum problem is still present, and there was the idea of the ciprofloxacin. The cipro also attained good plasma concentration, but the spectrum was improved, so we had gram negatives plus the pseudomonas. Pseudomonas also gram negatives, but it is resistant, but the ciprofloxacin covered it, and also it covers the Mycobacterium tuberculosis, so it has a better spectrum, but it still does not cover the gram positives. But the norfloxacin and the ciprofloxacin formed the second generation of the quinolone. So second generation of the quinolones are the norfloxacin and the ciprofloxacin. After those two drugs, or before that, sorry, the ciprofloxacin had a half-life of 4 hours. So 4 hours half-life plus the post-antibiotic effect. After the ciprofloxacin, there was the idea of the levofloxacin. Levofloxacin, this antibiotic solved or improved the spectrum of the quinolones, and it was better with gram positives. So it has better gram positive covering, and it also covered the gram negatives and the atypical microorganisms. And the half-life of the levofloxacin, it was 8 hours plus the post-antibiotic effect, and it formed the third generation of the quinolones. Now, the levofloxacin covered the gram positives and the gram negatives aerobic bacteria, but it does not cover the anaerobic bacteria. Same with the other three drugs, they did not cover the anaerobic bacteria. So there was the idea of the gemifloxacin and the moxifloxacin. And those drugs had same spectrum of the levo plus the anaerobes. They covered the anaerobic bacteria. And they had a half-life. The gemi had half-life of 8 hours. The moxi had a half-life of 12 hours plus the post-antibiotic effect. And those two drugs formed the fourth generation of the quinolones. After adding the fluorine atom into the structure of the nalidixic acid, now we call all of those quinolones, we call them the fluoroquinolones because of the fluorine molecule or fluorine atom added to their structure. Now let's talk about the pharmacokinetics of the quinolones. So with the pharmacokinetics, we always talk about the ADME abbreviation. The A stands for administration. So let's talk about the administration. First of all of the quinolones available as oral, so available as oral formula. We have the levo, the moxi, and the ciprofloxacin. Those are available as intravenous formula and ophthalmic preparations. They generally, with the oral formula, they have good absorption, except for the norfloxacin. Norfloxacin has incomplete absorption. Also, regarding the oral formula, ingestion of the oral formula with multivalent cations, so with multivalent cations like aluminum or magnesium containing antacids, or iron or zinc supplementations. Decrease absorption due to chelation. Decrease absorption due to chelation, and this problem also present in the tetracyclines. Now let's talk about the distribution of the quinolones. First, it is of molecular weight of 300 to 400, and it has good penetration to blood-brain barrier, so good penetration to blood-brain barrier, except for the first generation, which is the naldixic acid. So except naldixic acid, it does not cross. It has good penetration to body fluids, and it has good penetration to bones and joints. It also crosses the placenta and affect the cartilage of the growing fetus. So affect fetus cartilage during pregnancy, and it also cross into the breast milk and affect the cartilage of the growing child. So affect growing child cartilage during breastfeeding. So it is contraindicated in pregnancy and in children and teenagers less than 18 years. It also concentrates in the neutrophils in neutrophils, and that's why it has a good post-antibiotic effect. The metabolism of the quinolones is in the liver, and excretion is through the kidney. Except for the moxifloxacin, it is excreted through bile. All of them excreted through the kidney and changed. And that's why they are used to treat urinary tract infections. Except for the moxifloxacin, it is excreted in the bile, so it is not used for treating urinary tract infections. Now let's talk about the mechanism of action of the quinolones. Quinolones inhibit the topoisomerase enzyme of the bacteria. So topoisomerase enzyme. The topoisomerase enzyme is on 4 types. Type 1, type 2, which is also called the gyrase enzyme. Also type 3 and type 4. The quinolones inhibit type 2 and type 4. The gyrase enzyme type 2 is related to DNA, bacterial DNA relaxation during translation and transcription. So the gyrase function is relaxation of DNA, bacterial DNA, during transcription and translation, and inhibiting the gyrase lead to inhibition of the relaxation of the DNA during transcription and translation, and this would lead to DNA breakage, bacterial DNA breakage during transcription and translation. They also inhibit the topoisomerase 4, which is related to stabilization of the bacterial DNA during cell division. So stabilization of DNA during division, and inhibiting this enzyme leads to incomplete division of the bacterial DNA, and this would lead to death of the bacterial cell, and it is bactericidal drugs, so it kills the bacteria. The topoisomerase is also present in the human body, but the concentrations of the quinolones needed to inhibit the human topoisomerase should be very high, so the possibility of the human topoisomerase inhibition is very low. And now let's talk about the spectrum of the quinolones. We have 4 generations. So first, second, third, and fourth. The first is the nalidixic acid. The second is the noro and cipro. The third is the levo. The fourth is the moxi and the gemi. So starting with the first generation, the first generations cover the mostly gram negatives. The second generation covers mostly gram negatives. The third generation cover gram positives better than the gram negatives, and it also covers the atypical microorganisms. The fourth generation covers gram positives, gram negatives, atypical microorganisms, and anaerobes. The more you move to the right, the better gram positives cover. Better gram positive cover. Now let's talk about the resistance against the quinolones. So there is different resistance patterns, but the resistance against the quinolones is rare. But there is resistant patterns including the mutation in bacterial genes, mutation in genes that lead to less affinity of the quinolones to their binding sites in the bacterial DNA, and also the closing of the porine channels and the efflux pumps that would prevent the drug from entering the cell by the closing of the porine channel, and the efflux pumps would pump the drug out of the cell. And cross resistance is present in the quinolones. So if the bacteria have resistance against one drug of the quinolones, it means that it have resistance to the other drugs. Now let's talk about the therapeutic uses of the quinolones. First of all, they are used to treat urinary tract infections, especially the first and second generations. That's because they work on gram negatives, and 90% of the urinary tract infection are caused by gram negatives. They are also excreted in urine in the active form. So excreted in urine in active form. That what makes them very good in treating UTIs. They also are used to treat respiratory tract infections, and that's because, and especially the third and fourth generations. And we call them the respiratory quinolones because they are very famous in treating respiratory tract infections, and that's because they work on gram positives and atypical microorganisms which cause respiratory infections, and they also concentrated in neutrophils, and that's good in treating respiratory tract infections. They are also good in treating osteomyelitis because of the good penetration to the bone. And they are also good in treating meningitis because of the good penetration to the cerebrospinal fluid. And finally, they are used in treating atypical microorganisms infections. The first line is usually a macrolide or a tetracycline, but if those did not work, we use the quinolones. Finally, let's talk about the adverse effects of the quinolones. So we have the common adverse effects in form of nausea, vomiting, headache, and dizziness. We also have the musculoskeletal side effects. That's because of chelation with the magnesium. They affect the cartilage of the growing child and the fetus. That's why they are contraindicated in pregnancy and during lactation and in children and teenagers less than 18 years. They also cause tendinitis and tendon rupture for the same reason of chelation with the magnesium. They also cause central nervous system symptoms, so CNS symptoms, in form of seizures and central nervous system excitation. So seizures occur in people who are susceptible to seizures because the quinolones inhibit the GABA receptors. The GABA receptors act as inhibitory in the central nervous system, and inhibiting the inhibitory lead to central nervous system excitation, and it might lead to seizure in 1% of the people who have epilepsy. So it is low, but we should take it into consideration. Quinolones also increase the QT interval, same as the macrolide does. So the QT interval should be less than 0.45 of the second, and if it becomes longer than that, this is dangerous because it might lead to torsades, deep-point arrhythmia, and this might lead to ventricular tachycardia and death. So this should be taken into consideration, especially if the patient is taking another drug that prolong the QT interval, and the macrolides does the same thing. They also inhibit the cytochrome P450 in the liver, and this leads to a decrease in the metabolism of the cyclosporin, the warfarin, and the statin, and might lead to toxicity. And this problem also present with the macrolides. They also might lead to photoallergic reactions. So photoallergic reactions, because the quinolones are photosensitizing agents, and the photoallergic reactions might happen in people who take them and go get under the sun. This might lead to sunburn in these people. And finally, they cause super infections with the oral forms, with the long regimens. That's because they kill the intestinal flora and they leave the resistant organisms such as the Clostridium difficile, and this become dominant and lead to pseudomembranous colitis, lead to diarrhea and abdominal pain, and this is treated with metronidazole as the first line and oral vancomycin as the second line. Finally, let's talk about the contraindications of the quinolones. They are contraindicated in pregnancy and contraindicated in people less than 18 years because of the cartilage abnormalities, and they are also contraindicated in people with CNS disorders. And with that, we reach the end of this video. Thank you guys for watching. Please make sure to like and subscribe, and see you in the next video. Peace.